Hi, doctors. Welcome to the new episode of our A to Z series, where every day alphabetically we discuss one of the most repeated previous year topics of INI-CET, NEET PG, and FMGE. And today's episode is episode E, where E stands for ectopic pregnancy. So let's understand the key features of ectopic pregnancy with the help of solving some MCQs. All these MCQs are previous year questions. So our first question is, a patient with 6 weeks of amenorrhea and a positive pregnancy test came with complaints of lower abdominal pain, moderate PV bleeding. She was hemodynamically stable. On ultrasound sonography, there was no gestational sac in the uterus. Ovaries were normal and no free fluid in the pouch of Douglas. What is the next line of management? Option A, declare a complete abortion and follow up in 15 days. Option B, admit and observe. Option C, diagnostic laparoscopy. And option D, follow up with beta HCG. So which option do you think is the right one? Yes, the correct option is option D, follow up with beta HCG. In this scenario, the absence of a gestational sac in the uterus along with vaginal bleeding and lower abdominal pain raises suspicion of an ectopic pregnancy. The next step would be to follow up beta HCG levels to monitor the trend. Serial measurements of beta HCG can help determine whether the pregnancy is viable or if it is likely an ectopic pregnancy. Transvaginal sonography can see a gestational sac sooner than transabdominal sonography. So let's see the timeline. Transvaginal sonography is preferred because here gestational sac can be seen in 4+ weeks and cardiac activities in 5+ weeks. Whereas in transabdominal sonography, gestational sac is seen in 5+ weeks and cardiac activities in 6+ weeks. Laparoscopy is best, and if a woman is pregnant, cannot see a sac on TVS and HCG, is less than discriminatory zone, then see doubling titer. First, doubling in 48 hours, intrauterine pregnancy, uterus has better blood supply. Second, doubling in 5 to 7 days, it is ectopic pregnancy, more vascular insufficiency. Third, discriminatory zone, HCG level beyond which we must see a sac, TVS more than 1500 IU and TAS more than 6500 IU. So let's solve our second MCQ. A woman is diagnosed with an unruptured tubal ectopic sac. She is admitted for medical management with methotrexate while a strict watch is kept for signs of tubal rupture. An ectopic scar in which of the following parts of the tube is likely to rupture the earliest in case of failed medical management? A. Interstitial, B. Isthmus, C. Ampulla, and D. Infundibulum. Well, yes, the right answer is B. Isthmus. The isthmus is the narrowest part of the fallopian tube, located adjacent to the uterus. Typically, tubal ectopic pregnancies in the isthmus rupture within the first few weeks of gestation, with the ampulla being slightly more expandable. Other implantation sites, including the cornua and the abdomen, allow for further gestational development due to the increased space and ability to distend. Our next MCQ is about a 30-year-old female who was using IUCD for contraception, presents in emergency following 2 episodes of painless spotting per vagina preceded by amenorrhea for 8 weeks. She complained of lightheadedness and her blood pressure is 80/50 mmHg and the pulse rate is 138 beats per minute. With a positive urine pregnancy test, what should be the management of this patient? A. IV fluids followed by oral methotrexate. B. Immediate laparotomy. C. Stabilizing the patient followed by suction evacuation. And D. Dilatation and curettage. So the right option is option C, stabilizing the patient followed by suction evacuation. The patient is presenting with symptoms suggestive of ectopic pregnancy, a potentially life-threatening condition where the embryo implants outside the uterus, most commonly in fallopian tube. The classic triad of symptoms include missed periods, abdominal pain, and vaginal bleeding, along with signs of hemodynamic instability as seen in this patient, low blood pressure and rapid pulse, indicating possible rupture of ectopic pregnancy. In this scenario, the priority is to stabilize the patient due to her hemodynamic instability. Intravenous fluid should be administered to manage hypovolemic and stabilize her blood pressure. Once the patient is stable, the next step in management is suction evaluation, also known as suction aspiration or suction DNC. This surgical procedure involves the gentle suction of ectopic pregnancy and is the treatment of choice for hemodynamically stable patients with ectopic pregnancy. So our last PYQ for today's discussion is, which of the following is not an indication of expectant management in unruptured ectopic gestation? A. Initial serum beta hCG level less than 200 milli-international units per milliliter. B. Gestational sac size more than 4 cm. C. Asymptomatic. And D. Decreasing beta hCG measurement. Yes, the right answer is option B. Gestational sac size more than 4 cm. The indications for expectant management are: first, initial beta hCG level less than 1000 IU per ml and falling. Second, gestational sac size less than 4 cm. Third, no fetal heartbeat on TVS. And fourth, no evidence of bleeding or rupture. So that's all for today's episode. Thanks for watching and see you in our next episode, that will be episode F.